Hello, I am Dr. Lee Jongguk from Upgyujong Oracle Dental Clinic. In our last session, we talked about diagnosis in clear aligner treatment, and today I'd like to focus on guidelines for case selection. I've mentioned the importance of clinical judgment before. Think of it like baseball, it's always better to swing at a strike than at a ball. So in this lecture, I'll be sharing a general guideline on how to determine whether or not to take on a case. I show this chart in every lecture. Last time, we focused on diagnosis. Today, we'll shift our focus to case difficulty. While it is part of the diagnostic process, our emphasis will be on selecting cases that are more predictable in outcome. Now, I'm not saying we have to strictly categorize every case, but to make it easier to understand, I've broken it down into 4 levels: level 1, 2, 3, and 4. Now, this classification isn't set in stone, it's just a way to make things easier to understand. Level 1 or 2 cases are likely to lead to good treatment outcomes if you study hard. I always show you this image. This is the key question we should begin with. What kind of cases should we take on? I'll explain how you can approach this question and find the right answers. As mentioned in a previous session, we've talked about how to evaluate case difficulty. And in upcoming sessions, we'll also cover what to do when things don't go as planned. Now, coming back to the question of how to create space in non-extraction clear aligner cases, there are only 3 options: IPR, arch expansion, and molar distalization. When we look at it from a difficulty standpoint, the order goes like this. The lower on the list, the more challenging the procedure becomes. So, if sufficient space can be gained through IPR alone, you're likely to achieve predictable results. On the other hand, when molar distalization is required, the mechanics becomes harder, treatment time increases, and more variables come into play. Now, I'm not saying that every case must be treated this way. If, during your diagnosis, you find that sufficient space can be created with IPR alone, you can expect a more predictable outcome. Let's review the level of difficulty. First, when the patient's facial profile can be maintained, the case is generally less complex than when profile changes are required. Changing the facial profile requires significant retraction of the anterior teeth, which involves more complex mechanics and more variables. So let's assume we are maintaining the profile and take a look at the molar relationship, which is another key factor in determining case difficulty. But if changes are needed in molar relationship, more complex adjustments such as distalizing molars may be required. This factor can make a huge difference in case difficulty. To put it simply, if the molars don't need to be moved, the case tends to be less difficult. On the other hand, moving molars makes things more complex, so the molar movement is what determines the difficulty of the case. Lastly, as mentioned in the previous session, we can assess case difficulty based on the amount of crowding. I simply use 4 mm as reference point, but this number isn't absolute. It might be 3 mm or 5 mm. I simply use 4 mm as an average reference point. If you remember from the last session, when we discussed the amount of crowding, we talked about the concepts of available space and required space. For arch straightening, we can measure the arch length along either the purple line or the red line. There are various options. Now in this case, if we measure the arch along the red line, there is a 5.4 mm of crowding. But if we measure along the purple line, the amount of crowding is 3.4 mm. Naturally, a case with 5.4 mm crowding will be more challenging. So you may wonder why I set 4 mm reference point. If we rely on IPR alone to create space, about 0.5 mm of interproximal reduction can be performed at 5 contact points between the canines. And if we apply additional IPR posterior to the canines, we can gain 3 to 4 mm of space through IPR alone. So, if the crowding is within 4 mm, it can be resolved with IPR alone. But once it reaches around 5 mm, IPR alone is no longer sufficient, and you'll need to add complex mechanics to create the space. So, in my view, the level of difficulty changes around that 4 mm mark. If the crowding is less than 4 mm, the case is more predictable. Now, the second thing we need to understand is the types of tooth movement we can expect to see in the mouth during orthodontic treatment. The first type is what we call labiolingual tipping, or more simply, in and out movement. I'll just refer to this as in and out. This type of movement is known to be one of the highly predictable tooth movements in clear aligner treatment. In clinical practice, this type of movement is very useful in clear aligner treatment. So in cases where teeth are misaligned in the labiolingual direction, the treatment tends to be quite predictable. And when we say a movement is predictable, it means we can achieve the outcome as planned. Mesiodistal tipping is also fairly predictable with clear aligners. However, bodily movement and root movement are much less predictable. These types of movements are more challenging. So, depending on the type of movement, the level of difficulty can vary significantly. Next, both rotation and intrusion can be treated well with clear aligners. But among all types, in and out cases tend to achieve the predictable outcomes with clear aligners. So here, I've organized these movement types into 4 general difficulty levels, level 1 to level 4. Of course, we could say there is a level 5 or beyond, but let's focus on these 4. The key distinction between these levels lies in whether or not molar movement is involved. In cases involving molar movement, the complexity increases significantly. On the other hand, if the treatment is limited to the anterior region without moving the molars, it's usually a lower difficulty case. It can be a general guideline for making diagnostic decisions. Now, when I talk about level 1 cases, it's not that I'm rigidly classifying every case this way. But I've organized them to make it easier to approach. Level 1 cases include very mild relapse cases after orthodontic treatment, minor spacing, or mild crowding with more labiolingual misalignment rather than significant rotation. Relapse cases respond well regardless of which clear aligner system you use, and they typically don't take a long time to treat. Minor spacing or protruded teeth is also usually very manageable, as many of you already know. These would all fall under level 1 cases. Another example is mild spacing. It should be mild. Cases with large diastemas tend to be more challenging, but when the spacing is minimal, treatment is relatively easy. Now, with these spacing cases, you'll often find that any clear aligner system can resolve them in a short time. But there are 2 important things you need to be cautious about. When there's spacing between the anterior teeth, this is how they come together. In cases where the gap is relatively wide, we often see this type of movement. This phenomenon is quite common. We often refer to this as mesial tipping, and it tends to easily occur. If the space is narrow, it may close before any tipping occurs. So, it's important to be cautious of mesial tipping. The second point, especially in maxillary spacing cases, is that the upper teeth tend to move backward, which can lead to contact with the opposing teeth. So you have to be mindful of both mesial tipping and occlusal contact with the opposing teeth. As shown in the image, there's spacing between the upper front teeth and they're already touching the opposing teeth. Then no matter how much force you apply, space closure doesn't occur due to the contact with the lower teeth. This increases the likelihood of relapse. So, in these spacing cases, it's important to keep these 2 factors in mind. Next, we have cases where the teeth are misaligned in the labiolingual direction. These are the most representative cases for clear aligner treatment. Treatment time may vary depending on the case, but you can expect predictable outcomes. In these cases, the treatment can be completed within a reasonable time frame. Cases with protruded anterior teeth may take a bit more time, but overall, they still tend to achieve predictable outcomes with clear aligners. And these cases are quite common in pediatric patients. In practice, we often see cases of unilateral anterior crossbite, where only one side shows a crossbite rather than a full anterior crossbite. For this case, you can expect good treatment results with clear aligners. So once again, labiolingual crowding cases tend to respond very well to clear aligner treatment. To give you one more example, here's another case that was successfully corrected using clear aligners. If you consider these cases for your future clear aligner treatments, they can be quite helpful in clinical practice. Moving on to the level 2, I would like to highlight 2 points. In cases with large spacing, you need to be very cautious. As mentioned earlier, tipping can easily occur, so it's important to think about how to move the roots as well. Therefore, we need to use additional tools like attachments, which help facilitate root movement. So, for cases with significant anterior spacing, we can gradually close the gaps using attachments. To summarize, even if there is a large spacing, as long as we use attachments properly and the patient wears the aligners well, we can close the space without causing mesial tipping. I want to emphasize that such cases require caution. Next, when it comes to rotation, most cases are manageable. In the past, rotation was considered a difficult movement to correct. But now, thanks to improved attachment materials, I believe rotation in crowding cases can generally be treated successfully. Various case types exist, including those involving the lower arch. The smaller size of the lower teeth may seem challenging, but treatment generally proceeds smoothly, even if the duration varies. So, when we look at the big picture, cases involving labiolingual movements, rotations, or spacing issues generally fall into level 1 or 2. As long as we approach them with caution, these cases can lead to favorable outcomes. On the other hand, cases involving changes in the molar relationship tend to be more challenging. I'll just give a brief explanation here, and we'll cover these cases in more detail later in the course. So, when molar movement is involved or when there's a significant amount of crowding, more variables tend to occur. For example, in cases where the anterior teeth are protruded, and you're trying to correct them by distalizing the molars, the treatment takes longer and often involves some trial and error. These cases require more in-depth study. In this case, after distalizing the molars, the outcome has improved significantly. As the occlusion improves from a class 2 tendency to a class 1 relationship, the teeth become more aligned. You can see this improvement in the before and after images. So, if molar distalization is involved, you should recognize that the case is more complex. Finally, there are cases where arch expansion is used to create space, in combination with IPR. However, when expansion is involved, it can lead to changes in posterior occlusion. So we often find ourselves facing challenges when addressing those occlusal changes. Of course, there could be level 4 or even level 5 cases. But for beginners, I recommend focusing on level 1 and 2, and then you can achieve good outcome. As for level 3 and 4, it's better to approach them after gaining more knowledge and clinical experiences. To summarize, today we discussed some guidelines for case selection. In the last session, we covered diagnosis. And we'll take a closer look at how to proceed with selected cases, how to place orders, manage the process, and finalize the treatment. Although I kept things simple today, I encourage you to build on this framework and add more detail to develop a more structured approach. That's all for today. Thank you for your attention until the end.